Now we're shifting to the clotting factors themselves, and each clotting factor has a unique role in the coagulation cascade, and deficiencies can lead to characteristic changes in PT or APTT. Factor assays allow us to measure specific factor concentrations in the blood. Understanding which factor is deficient helps us pinpoint the exact cause of a patient's bleeding disorder and guides targeted replacement therapy. Normal ranges for clotting factor concentrations vary, but generally fall within about 50 to 150% of normal. For example, we can see factor 2 exhibits a percent range of 80 to 120%, as seen on this slide. When levels are below these ranges, patients may present with bleeding tendencies. Conversely, elevated levels can be seen during pregnancy, inflammation, or oral contraceptive use. Factor assays are essential in diagnosing inherited conditions like hemophilia or acquired deficiencies due to liver disease or vitamin K deficiency. It's important to review which coagulation tests are affected by specific factor deficiencies. For example, fibrinogen deficiency prolongs both PT and APTT, while factor 7 deficiency only affects PT. We think of factor 8 or 9 deficiencies, as in hemophilia A and B, prolong only APTT. And then, of course, other things can affect both pathways. This pattern recognition is critical for interpreting coagulation profiles and deciding which factor assays to order next. Connecting clotting factors back to their sources and their pathways are also helpful, as most clotting factors are synthesized in the liver, and several are also vitamin K dependent, including 2, 7, 9, and 10. Factor 8 comes from platelets and endothelial cells, while tissue factor is released from damaged cells. Calcium, factor 4, comes from the diet and bone metabolism and is required throughout the clotting process. By mapping each factor to its pathway, intrinsic and extrinsic or common, we can better understand how specific deficiencies translate into abnormal lab findings. When measuring clotting factors, it's important to remember that results can be affected by outside influences, as many clotting factors are heat sensitive, so if blood samples are left at room temp, the factor levels can drop artificially. Pregnancy and oral contraceptive use can increase factors, especially 8 and 9, which could mask a mild deficiency. And acute illness, stress, inflammation, or exercise can elevate acute phase reactant proteins like fibrinogen or factor 8. So we must consider these variables before concluding that a patient has a true clotting factor abnormality. The collection is the same, a blue citrate top and not fasting. Sometimes, although more rare, we can see elevated clotting factors. Fibrinogen or factor 1 increases during acute inflammatory states, trauma, or with chronic conditions like coronary heart disease. It also increases in smokers. Factor 8 can elevate during pregnancy with oral contraceptive use or during stress and inflammation. While increased levels can be harmless, they also could contribute to hypercoagulability, putting patients at risk for thrombosis. A decreased fibrinogen level can result from liver disease, DIC, or congenital deficiency. Low prothrombin or factor 2 is most often due to vitamin K deficiency, liver disease, congenital deficiency, or warfarin therapy. Since both fibrinogen and prothrombin are key to forming stable clots, deficiencies here often present as significant bleeding tendencies. Factor 5 or proaccelerant can be decreased in liver disease, DIC, and fibrinolysis, versus factor 7 is partially or particularly important because it prolongs PT without affecting APTT. Causes could be vitamin K deficiency, liver disease, congenital deficiencies, and warfarin therapy. The isolated PT prolongation often points us towards a factor 7 deficiency as the likely culprit. Now, factor 8 deficiency is the hallmark of hemophilia A congenital bleeding disorder. It also can be decreased in disseminated intravascular coagulation. And von Willebrand factor is closely linked since it helps to stabilize factor 8. Deficiencies in von Willebrand factor lead to both quantitative and functional platelet problems, prolonging APTT and causing bleeding symptoms. Autoimmune conditions can also reduce von Willebrand factor levels. Factor IX deficiency can cause hemophilia B, which is also called Christmas disease. Like hemophilia A, it prolongs APTT. Yep, it does. Factor just wanted to confirm. Factor IX levels may also be decreased in liver disease, nephrotic syndrome, DIC, or vitamin K deficiency. Warfarin therapy reduces factor IX as well. Recognizing this helps us differentiate between inherited and acquired causes of prolonged clotting times. Factor X, also called Stewart factor, can be decreased in congenital deficiencies, liver disease, and vitamin K deficiency or warfarin use and DIC. Factor 12 or Hageman factor is also synthesized in the liver, and deficiency prolongs APTT, but usually does not cause clinical bleeding, as patients may have abnormal labs but no symptoms, which highlights the difference between lab abnormalities and clinically significant bleeding risk. Now, this table will pull everything together by comparing our PT, our APTT, PFAs, TTs, and congenital deficiencies, tying them back. And it can be a great way to kind of study these different factors and these different conditions.